A fundamental question then, is obesity a disease?
Obesity, in my opinion, and the opinion of many scientific colleagues in the field, is clearly a disease. Now, there is still controversy about this. I will not deny that, and I can also, to a certain degree, understand the opposing view. Now, the reason why obesity is a disease is because we know that the biological drivers that control our body weight are very, very powerful. So what we know is that approximately 70% of anyone's body weight is determined by their genetic makeup. And the other 30% depends on other environmental factors. Therefore, we cannot ignore such a big number. The genetic makeup of all of our appetite regulation system sits in the brain, and it sits in areas that control hunger and fullness. And it happens that in the disease of obesity, the circuits that control hunger and fullness are disrupted because of genetic mutations. As a result, this causes the symptoms of obesity, and the symptoms of obesity are high hunger and low fullness. So those of us that have obesity and those of us that are of normal weight are just lucky. We are not smarter, and we are not more educated or hardworking or have more willpower than those that do not. Now, I've talked about the biological drivers, but this doesn't mean that we should ignore the other 30% or so of the environmental drivers of obesity. And there are many of those, and the correct way of treating the disease would be to address them. For example, this is healthy nutrition, access to physical activity, psychological support, social support, etc. In order to treat the disease more effectively for people that have it. At the same time, these environmental issues need to be addressed for the prevention of obesity in order to reduce the number of people that develop the disease in the years to come. So this is not just about treatment, and it is not just about prevention. It is about doing both.
So following on from what you've said, will it be necessary to take semaglutide for life, or will a short course be enough?
I get asked this question about medications a lot, as to whether our appetite centers in the brain can be trained with the medication or any treatment for obesity. And the answer is largely no. We know, not from only from our own experience, but also from randomized controlled clinical trials, that when the medication is stopped, the vast majority of people regain the weight that they have lost. And this is because, unfortunately, the medication or even bariatric surgery does not train the appetite centers of the brain to behave in a certain way. They only work while they are there. It's the same approach with hypertension, high blood pressure. When someone is taking a blood pressure medication, it works because it changes the biology of blood pressure regulation. The cardiovascular system does not learn or get trained on how to deal with hypertension. So when the pill for hypertension is removed, the blood pressure increases again. And almost exactly the same principle applies for obesity. So therefore, that means that the people who suffer with the disease of obesity need to be treated for life. They don't have to be on the same medication. They don't necessarily have to be on Wegovy. Medication can be changed, or they can have surgery, bariatric surgery. They can have a combination of medications with surgery plus nutritional therapies, psychological therapies, physical activity therapies. But the ones that are effective need to be continued long term. And what you have highlighted demonstrates one of the weaknesses of the NICE guidance that we have already talked about, which is this 2-year course. But again, overall a good change in the treatment of obesity in the UK, and we will need to find ways of how to deal with this shortcoming in due course.
And standing back a bit, will the use of semaglutide for obesity actually prevent cardiometabolic problems for an individual further down the line?
So the great thing about what we have already discussed is that these medications for obesity, including semaglutide, have already been shown to reduce the number of people who develop diabetes, for example. They reduce blood pressure, cholesterol, etc. So their metabolic profile is very good. But what we do not know for any of those medications is whether they reduce the incidence of cardiovascular events. So whether they have got any effects on hard clinical outcomes. However, we will find at least the initial answer to that question probably around September this year. This is because the SELECT trial is going to report them. This is one of the biggest trials conducted in the field of obesity. 17,000 patients or so with established cardiovascular disease were randomized to semaglutide 2.4 milligrams versus placebo, and they were followed up for about 4 years. And I was privileged to be contributing to this trial in my unit. This trial is coming to an end as we speak, and we are really looking forward to the results because they will really change the way that we deal obesity, and we will now have evidence not only for risk factors for cardiovascular disease, but actual hard outcomes.
Professor Miras, thank you very much for sharing your experience and expertise on the use of semaglutide for obesity management with us today. I know many people will find that very interesting. For more information about Professor Miras' work, please visit our website using the link in the description, and be sure to subscribe for more news, videos, and journals. For updates straight to your inbox, please follow the link below. And thanks for watching.